Good afternoon, everyone. On behalf of MSN Labs Private Limited, I would like to welcome all of you for today's our session on the novel treatment approach for the management of pulmonary arterial hypertension. Before getting into the today's scientific session with the kind permission of today's moderator and speakers, I would like to go through for just brief introduction about our organization as a whole. So on behalf of MSN Labs Private Limited, myself, Nitin Kumar Chaturvedi, along with my Senior Vice President, Mr. Ashish Gupta, and Senior General Manager, Mr. Sushant Jana, sir, and my Marketing Manager, Tanmay Mandal, sir, I would like to welcome all of you for today's session. Innovation resonates a sense of purpose in the human life, and the creative capacity of human mind has always been the source of inspiration. We believe every life matters and everyone deserves the quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human lives. So welcome to the global research portfolio of MSN Lab with 1,400 dedicated team of scientists. We have got 17 plus world's first branded generics. We have got 42 scientific labs and 2 pilot plants, and making it Asia's largest R&D center, and 690 plus patents for API formulations. And we have got a global manufacturing quality manufacturing facilities, which is available in 11 in India as well as 1 in US. And we have got 30 plus approval from the leading authorities world like US FDA, UK MHRO, WHO, and many more. And we have got 300 plus bioequivalent formulations and 450 plus API manufactured. And we have got a global presence. As you can see that we are present in 65 plus countries worldwide. We have got 410 plus global leader in the active US DMF filings and offices present in US, UK, Colombia, and so on. And we have got 2,000 plus dossiers filed globally. So we have been always pioneer to bring some new therapies in the Indian market, like in PH, whatever is available today. We were the pioneer to bring each and everything, like Pulmonex, then Selepeg, Macitand, then Receptor, and everything. And we are very glad to introduce our Selepeg today. And in the hyponatremia management, we brought Tolvaptan for the first time in India, then Dapavan and Azilura. And in the antiplatelet management, we were the company to bring all the molecules like Prasugrel, Ticagrelol, and we have brought the India's first injectable antiplatelet very recently, that is Cangrelor. So we are constantly innovating and evolving to create. We are coming these molecules in the diabetes management: sitagliptin, linagliptin, empagliflozin, and FCM. So to partner in creating awareness in management of pulmonary arterial hypertension approach for emerging treatment options that to create patient life expectancy and quality of life. Our today's session is there on the pulmonary, the novel approach for the treatment of pulmonary arterial hypertension. In fact, just to share with all of you that 10 years back, once we entered into the segment of pulmonary arterial hypertension, it was being considered as a rare and orphan disease. But now with the changing modalities and treatment options, it is no more a rare and orphan disease, and many more patients are diagnosed and many patients are being treated appropriately. In this field, there has been a remarkable contribution from our today's world-class faculties which are there with us. And it is our honor to welcome our, first of all, today's moderator, Dr. Deepak Talvasar. Dr. Deepak Talvasar is a director in pulmonary sleep and critical care medicine at Metro Institute of Health Sciences at Noida. He has fellowship from various national bodies like American College of Chest Physicians, National College of Chest Physicians, Indian Sleep Disorder Association, and Indian College of Allergy and Immunology. Dr. Deepak is having a good exposure since 2008 in teaching in charge of DNB respiratory medicine, and many are all across India. We can find his DNB students doing a good work and pioneer work in the field of respiratory medicines. First, and then we have got our today's first speaker, Dr. P.D. Rath, who is a director in DNB Rheumatology Training Program at Max Hospital, New Delhi. And Dr. Rath has worked as an examiner for DNB Rheumatology and MRCP cases. He is a supervisor of clinical and educational core medical training, and he is executive committee member of various bodies like Indian Rheumatology Association, Delhi Rheumatology Association, and so on. And Dr. Rath is the first rheumatologist in India to be certified in MSK ultrasonography. And today's our second speaker for the session is Dr. Vikas Kohli, sir. Dr. Vikas Kohli is associated with the functioning of various professional bodies like related to pediatric cardiology, and he has got the best fellowship award from American Heart Association and American College of Cardiology. He is an expert in online eco training courses and fellowship from pediatric cardiology supervisor. And Dr. Kohli has worked as an examiner for final fellowship exam in pediatric cardiology at many forums. So with this short background, I would like to first of all hand over the session to today's our moderator, Dr. Talvasar. Dr. Talvasar, over to you, sir, please.
Thank you, Nitin, and welcome you all. I know that it's an exciting time for this webinar to come, and a lot of friends who have joined today would be wondering that the focus on pulmonary hypertension is something which keeps coming and going. And I think the impetus comes every time we have a new drug coming up to treat the disease. My encounter with pulmonary hypertension goes back to 2006, 2007, 8, 9, 10, when there were trials on PAH, particularly by Pfizer for sildenafil. And there was a lot of difficulties in recruiting patients, right heart catheterizations. But despite that, India did some good work in the research in the field of pulmonary hypertension. We know that we had a lot of unmet needs in not only respiratory field, but other fields where the pulmonary hypertension is encountered. And two most important, cardiology and rheumatology, are going to be represented by Dr. Rath and Dr. Vikas in this webinar today. They will be talking about the role of this anti-PH drugs in their respective fields. And me being a pulmonologist has always been at the corner of the pulmonary hypertension because by and large, the therapies have not shown good results. So basically for us, pH is a marker of poor prognosis and a poor survival. Just sitting without doing much for these patients is very frustrating. But yes, we do overlap a lot with idiopathic as well as from the field of rheumatology, because a lot of sarcoid associated as well as ILD related pulmonary hypertension is also pouring into our practice, where we feel that the standard of anti-PH therapy cannot be completed, primarily because we had just two groups of drugs available. We started with one, we had another one, but then we could never go for a triple therapy. And for a respiratory physician to talk about triple therapy is like it is there in all the diseases, asthma, COPD, it's everywhere there actually, including ILD. So what we talk about is today that the disease like pulmonary arterial hypertension needs an aggressive therapy. And the new norm is definitely not a monotherapy. It starts with a double therapy, but needs to be upgraded to triple therapy as and when required, which invariably will happen over a course of time. These were the patients who had a poor prognosis, poor survival, requiring heart and lung transplants and heart transplants. But then ultimately the therapy has changed the entire scenario of pulmonary hypertension. They live much longer, they live much better, they have a better quality of life, and they live oxygen free for a very long time. I know lung transplant and heart transplant is not an option to most of our patients in India, although we are getting them done now, but it's still not an option. So with the drugs, how it is changing, and we are always been talking about prostacyclin blocking pathway. And today is the great day, and I think I can congratulate MSN team because we were waiting for something to come on this pathway. And nothing better could have come as the oral therapy of oral prostanoids have come. We are going to talk about Selexipag today, which is the new drug, oral prostacyclin blocker. And of course, its role in various diseases, which has been already done and researched. And for that, we will have the first presentation from rheumatology aspects, and that is Professor P.D. Rath. We know Dr. Rath, he's an excellent rheumatologist with a very good and outstanding background in the field of rheumatology. And that is one field where you get this pulmonary hypertension, where really it troubles the dyspnea and of course, limiting the outcomes. So over to you, Dr. Rath.
Thank you, Dr. Deepak. It's a pleasure and honor to be sharing the dais with you and Dr. Kohli, and thanks to MSN. And I really agree with you that there's been a lot of gap in the management of PH. And I think Selexipag hopefully will plug that gap and help us, treat our patients in a better way. As you know, that scleroderma and ILD and scleroderma PH is one of the burning issues for us rheumatologists. And PH is, of course, a very difficult thing to diagnose. And I absolutely agree with you. I share the same sentiment. I believe that we need to do combination upfront, because this is one disease where every deterioration is irreversible. So, and rheumatologists, we have always believed in combination therapies right upfront and with step down with time. So thank you so much. And I would request now to please start the talk. Thank you. Thank you.
A very good afternoon to all of you welcome to this afternoon session on pulmonary artery hypertension. I'm going to talk about connective tissue disease PH and specifically scleroderma PH. And I will be talking about this new molecule called as Selexipag. Let me just share my screen. Right. So pulmonary hypertension was defined earlier as a resting mean PAP of more than 25 measured during right heart cath. And now we know that definition has been revised, and we know that now it's more than 20 on a mean PAP with a PVR of more than 3 Woods unit. And this stands good for precapillary pH. And for others, we have other definitions. I'm not going to go into that. We also know that the Venice classification in 2003 divided pH into 5 clinical subgroups: the PAH, pH due to left heart disease, pH due to chronic lung disease, CTE pH, and pH with an unclear etiology. So in the current classification system, on one hand, you have groups like 1 and 4 where we have defined treatments. And on the other hand, you have groups like 3 and 5 and 2 where the optimum treatment is not yet clear. Now, connective tissue diseases also are a very important causes of PH, and amongst them, scleroderma is the leader. And when it comes to CTD PH or scleroderma PH, rheumatologists do play an integral part in the detection and co-management. But we do this along with collaboration with our friends in pulmonology, cardiology, because given the complex nature of PH and its diagnosis and management, it is important to partner with our colleagues in cardiology and pulmonology, and that's what makes this field so very interesting and exciting. So when we look at PH and Ctd and systemic sclerosis, we see that Ctd is one of the leading causes of PH, only second after idiopathic PH. And when we look at all the Ctd PH, we find that scleroderma accounts for majority of them, followed by MCTD, lupus, dermatomyositis, rheumatoid, and other causes. So almost 74% of CTD PH is scleroderma, 8% is lupus, and the rest is MCTD and other diseases. And not only that, scleroderma is also one of the leading causes of death from PH amongst the connective tissue disorders. When we look specifically at the scleroderma group, we find that diffuse scleroderma is less associated with PH, 33%, as compared to limited scleroderma, which is one of the most commonly associated with PH, almost 67%. And amongst the CTD, why it is important to talk about scleroderma PH is because scleroderma PH, as you can see, is perhaps much, much worse than the other PH, specifically those associated with lupus. And what also makes scleroderma PH detection very important is because scleroderma PH patients fare much worse as compared to even idiopathic PH. And that's probably also because not only PAH, but in scleroderma, PH as such, pulmonary hypertension as such, is multifactorial. So they have multifactorial causes. They have pulmonary artery hypertension. They can have pulmonary cardiac involvement, as I'll show you. They can have lung fibrosis. So multiple causes of PH. And PVOD, which is one of the under-recognized causes of PH, is again a cause of PH in scleroderma patients. One of the key or tricks is, of course, the cardiologists know that is when you put a patient on vasodilator and they start developing pulmonary edema, you start thinking of PVOD. So in scleroderma, what happens is pulmonary hypertension can also happen due to left heart disease. And surprisingly, cardiac involvement, though under-recognized, second to lung, though most of the focus goes on lung. But as you see, cardiac is also very much involved in scleroderma. The left ventricle, the posterior wall, the left atrium, the mitral valve, the aortic valve, everything can get involved. Now, the most common, of course, that we know or we recognize is PH secondary to pulmonary fibrosis, apart from PAH. And what makes it very important is because PH, when associated with pulmonary fibrosis or ILD, is again much worse as compared to isolated pulmonary hypertension. So you can see that a patient of scleroderma can simultaneously have pulmonary hypertension due to multiple causes. It can almost fulfill all the different classes of Venice at the same time. That's why it becomes very, very important to screen for this. Because when you look at scleroderma as a disease, those patients of scleroderma who have PAH fare much worse than those who have other organ involvement such as lung or other organ involvement. So clearly, PAH in a patient of scleroderma also is one of the worst prognostic factors. Now, what are the methods for screening? And the initial or one of the earliest was the Itinerary Scleroderma study. This was done with 559 patients without severe pulmonary function abnormalities who underwent echo. And what they looked at was the peak velocity of TR or BTR. And if it was more than 3 minutes per second or more than between 2.8 to 3 minutes per second, unaccompanied by unexplained dyspnea, then they underwent right heart cath to confirm PH. So clearly those who had a VTR of more than 3 minutes per second underwent a right heart cath, and those between 2.8 to 3 who were symptomatic underwent a right heart cath. So based on the Doppler echo, 33 of these patients had suspected PH. But when a right heart cath was done, PH was detected in only 18 of these. So clearly, echo may be a good screening tool, but echo has its own limitations. It tends to overestimate PH as compared to right heart cath. So PH can never totally be diagnosed with confidence on an echo. So what are the other methods of screening? This is a very, very useful method developed by the Australian Scleroderma Interest Group. So they've taken two components, component A, which is an NT-proBNP of more than 210 picogram per ml, and a component B where the DLCO is less than 70% with an FVC DLCO ratio of more than 1.8. And what they did was, if either of these components was positive, then the patient was referred to a right heart cath. And what they found was 1 in every 3 patients had PH detected on the right heart cath. The other, of course, is the echocardiography based screening, which I just told you. And then the detect algorithm, which is again an algorithm which is based on certain scores. And step 1, and once you fulfill this particular score on step 1, you go to step 2, which is an echo variable. And when we look at a comparison of all this, the ASIG, the detect, and the ESC or ERS criteria, we find that the ASIG really scores. It scores very well along with detect with a sensitivity of both for almost 100%. But when it comes to specificity, you can see that the ASIG scores much over detect with almost a 47.1% specificity, a positive predictive value of 60%. Detect has almost 55.1%, quite close. And both detect and ASIG have a negative predictive value of almost 100%. So I particularly find the ASIG very useful because it is not very expensive. You can do it on the basis of a simple PFT and a blood test. Now, but very often we use an echo in our country. So how do we go about it? And there are no guidelines. This is a postulated guideline, you can say, by Dr. Dinesh Khanna and myself and Dr. Khan, and we sought and thought about this. Though this is not published, but this is a possible recommendation which could happen, which is like, if you have no TRJ or an ER-RVSP of less than 35, you do nothing. If you have an ER-VSP of 35, ejection RVSP of 35 to 50, with no sign or symptoms, you do an anti-proBNP if it's more than 2 times the upper limit of normal, or there's a decline in DLCO, then you treat. If there are no symptoms, you confirm with another echo, because we know that there's a lot of observer variability with echo. And the repeat echo again shows between 35 to 50, then you do an anti-proBNP if it's more than 2 times the upper limit of normal, and there's a decline in DLCO, then you start treating. However, if the RVSP is more than 50 with sign and symptoms, you treat. Without symptoms, you again need to confirm it by doing another echo from another source because of the problems of variability, observer variability in our country. If it is the repeat echo is again showing RVSP of more than 50, then you do the anti-proBNP if it's more than 2 times the upper limit of normal, or there's a decline in DLCO, you could treat. So this is one of the possible algorithms which we could use for detection of PH in our country. Now, apart from the conventional risk factors, we also know that anti-proBNP and telangiectasias more than 10 can be the other risk factors. Before we move on to the specific vasodilator therapy, the question that often comes in people's mind when they're dealing with a CTD-PH is that, is there a role of immunosuppressive therapy? So this was a study by Sanchez and et al. In CHEST 2006, where they looked at immunosuppressive therapy in CTD-associated PH. And what they found was that 29% of these patients responded, and mainly the SLE and MCTD subgroup. However, they noted that no patients with systemic sclerosis responded to treatment. And you can look at this, the group A and B, and you can see that cyclophosphamide at baseline in patients given without PH and with PH at the end did not make any difference. So clearly immunosuppressive therapy had no role then, until the FARO study took place. And the FARO study showed something very interesting. It showed that people who are on MMF, if you look at their mean PAP, PVR, capillary wedge pressures, FVC, DLCO, and 6-minute walk distance was significantly better as compared to the no immunosuppressive therapy. And the observation was so fascinating that there was also, if you look at the survival across the groups, partitioned by FVC and MMF use. So the black is more than 70 on MMF, the red is more than 70, no MMF, the blue is less than 70 MMF, and the green is less than 70, no MMF. So what they found was that there was a trend for improved survival in patients with PH with an FVC less than 70, who were treated with MMF even in the absence of improvement of FVC, which is very, very intriguing. Now, whether it has an effect on pulmonary artery remodeling has to be considered. We know that MMF is an antifibrotic agent. So clearly, there are some very interesting signals from the FARO study about MMF and pulmonary artery hypertension. However, it needs to be validated in future studies. Now, when we look at the clinical subtype and when we look at the multivariable predictors for pulmonary artery hypertension, we find that apart from age, limited cutaneous involvement, and antibodies such as THTO or U3-RNP, which show a nucleolar ANA, are risk factors for predictor of PH. And when we look at secondary PH, again, age, male, U11, U12-RNP, anti-centromere antibody, and limited cutaneous involvement are clear predictors of development of PH. In the antibody profile, you can see, of course, as expected, anti-centromere antibodies have the highest chances of PAH, followed by U3-RNPs, THTO, U1-RNPs. But what you see is across the antibody class, PAH can happen. For example, with anti-topo antibodies, even though it's less common as compared to PH-ILD, PH can also happen. So multifactorial in all the antibody subgroups. In some PAH is more common, in some PH-ILD is more common. So, but that is the uniqueness about scleroderma. What is also very fascinating is that the NT-proBNP in systemic sclerosis has a very independent prognostic value, even without pulmonary artery hypertension. So patients who have high BNP fare much worse than patients with low BNP, irrespective of pulmonary hypertension. Now, we've always thought and believed that the treat to target was that the patient should achieve a 6-minute walk distance of at least 400 meters, and that the patient should be on functional class 2, because functional class 2 had a significantly better survivability as compared to functional class 3 and 4. However, when we see the REVEAL registry, and it actually reveals very, very interesting findings. What it shows that functional class 2 PH patients were as likely to clinically worsen within 1 year as those in FC class 3. It's almost same, 43 to 45%, breaking the myth that an FC2 patient does better than an FC3. And almost 1 in 4, which is 24% of PH-related hospitalizations occurred in newly diagnosed functional class 2 patients. Also, what was important is in the FC3 group, more than half, 56% of PH-related hospitalizations occurred. And when we look at the DETECT study, more than 40% of PH scleroderma patients progressed during a very short time, a median observation time of 12.6 months, suggesting that we need to treat them very, very early on. Now, when we look at the treatment of PH, we know that there are mainly 3 groups of drugs, one targeting the endothelin pathway like the ERAs, the nitric oxide pathways or the PD5 inhibitors, and the guanylate cyclase stimulator like riociguat, and the prostacyclin pathway. And this is where we talk about the newer modality today, which is Selexipag, which is nothing but an IP2 agonist and therefore works at the prostacyclin pathway. Now, two very important studies, the Griffon and the Triton. The Griffon is one of the largest PH-CTD subpopulation, had the largest population of CTD PH in a randomized controlled PH trial. So I'm going to talk about this. When we look at the baseline patient characteristics, mean age was 48 years, 80% females, 80% were on PH background therapy, almost 33% on ERA and PD5 inhibitors, 32% only on PD5 inhibitors, 15% on ERA, and 20% on none. And when we look at the functional class, equally divided, almost 50% functional class 2 and 50% functional class 3. Etiology, almost 30% had PH-CTD and another 10% had PH due to CHD. So when we look at the PH-CTD, this was a pre-specified subgroup for the Griffon phase 3 trial. And when we look at this subgroup, 51% was scleroderma PH, 24% was lupus PH, and the other 24% were MCTD or other CTD related PH. Again, 50% of the patients were class 2 and almost 53 were class 3. Almost 30% on dual ERA PD5 inhibitors, 28% on mono PD5 and 20% on mono ERA. So almost 77% were on some kind of background therapy. Now, when we look at the time to disease progression event, we find that almost 58.2% of patients in the Selexipag group were event-free at the end of 3 years as compared to 41.7% in the placebo group. So 40% risk reduction in disease progression was seen at the end of 3 years with Selexipag. Not only this, when we look at the hospitalization for PH, very significantly lower with Selexipag, 13.6% as compared to placebo group, which of course had the other vasodilator therapies in it. And when we look at the other markers of disease progression, such as decrease in 6-minute walk distance and worsening of functional class or need for other therapy, we find that almost 6.6%, only 6.6% in the Selexipag group as compared to 17.2% in the placebo group. So clearly, very good, important improvements in endpoints of disease progression. So what we see also that Selexipag reduces hospitalizations. So almost 13.6% hospitalization with Selexipag as compared to 18.7% with placebo. So significantly less hospitalization in patients on Selexipag. What was also seen and as expected was that if you initiated Selexipag before 6 months, as early as 6 months with the diagnosis of PH, there was almost a 55% risk reduction. However, what was also very important is that even if you initiated it after 6 months, there still was a 26% risk reduction with Selexipag as compared to placebo. Now, what about the triple combination subgroup? So 33% of all patients in the Griffon were receiving ERA PD5 at baseline. And the etiology in this triple combination subgroup was almost 26% of these patients had PH-CTD. So clearly the triple combination subgroup had a longer time from diagnosis. They had larger percentage of West European and Australian patients and a larger percentage from North America. Now in this subgroup, which was the triple combination Selexipag, ERA and PD5 inhibitors, again they found that there was a 37% risk reduction in the progression of the disease. This was much more pronounced in the functional class 2 subgroup, which is obvious. So 64% reduction in the FC2 group and 26% risk reduction in the functional class 3 subgroup. So clearly Selexipag in combination with endothelial receptor agonist and PD5 inhibitors had a clear benefit over placebo or dual therapy. Now, the post-hoc analysis also showed that there was a 41% risk reduction of disease progression in PH-CTD patients treated with Selexipag. So clearly, again, there was a very significant improvement overall. And when we look at the scleroderma subgroup, again, you find that 334 patients in the Griffon study, for 51% had PH due to scleroderma, 1/3 were in functional class 2, and 2/3 were in functional class 3. 78% were on background therapy, 36% on a combination of ERA and PD5, 23% on PD5, and 80% on ERA. So the risk reduction of Selexipag versus placebo was much higher, 44% in patients with PH scleroderma, which we know is a bad disease, as compared to 34% in patients with lupus PH. So clearly in a subset of CTD, which is scleroderma, which I showed you is associated with a very bad pH, it showed much better improvement. Now we all know the most frequent adverse events are, as expected, headache, diarrhea, dizziness, vomiting, peripheral edema, and most of them are mild and rarely require discontinuation. If you start very slow and gradually escalate the therapy, usually well tolerated. And finally, I come to the Triton trial. Now, this was an initial triple versus double oral combination therapy in PAH. So the newly diagnosed treatment-naive patients with PH were inducted into this trial. And this was a double-blinded, multicentric, randomized, placebo-controlled trial, phase 3B. One group received the dual therapy as the initial treatment, macitentan and tadalafil, plus placebo. And the second group received initial triple combination, which was macitentan, tadalafil, and Selexipag. Now, when we look at the change from baseline to week 26, when it comes to pulmonary vascular resistance or 6-minute walk distance or NT-proBNP, there was not much difference. But that was probably because of the short duration, which is 26 weeks is probably a very small duration to know a difference between the two treatment groups. But when we look at time to first disease progression events, we find at the end of 30 months, almost a 41% reduction in risk of disease progression with the initial triple therapy, which included macitentan, tadalafil, and Selexipag, versus initial double combination, which is macitentan and tadalafil. So clearly showing that initiating with triple therapy and a combination of Selexipag onto that triple therapy significantly reduce the risk of disease progression. So clearly Selexipag is one drug, and this was presented recently, that when we look at time to disease progression, the effect of Selexipag is so profound that if you look at the Griffon and Triton pooled analysis, you find that this is one drug which can significantly retard or slow or prevent the time to disease progression. And that's what makes this a very, very interesting and exciting drug in our armamentarium, in our fight or in our treatment against pulmonary artery hypertension. Also, when we look at the real world data and we compare Selexipag with the other drugs of this group, which is oral treprostinil, we find that Selexipag fares much better than the other prostacyclin analogs, with almost a 47% risk reduction in the Selexipag group as compared to oral treprostinil, which is one of the most commonly used prostacyclin analogs world over. And this is again a real world data. So it shows the superiority of Selexipag in the prostacyclin group itself. So clearly Selexipag has been seen in all the event-driven trials to be beneficial as mono, sequential dual combination, sequential triple combination, and also initial triple combination therapy. So to briefly summarize, we know that PH is a relevant complication of CTD, especially scleroderma is one of the most important causes, followed by lupus and MCTD. The best therapeutic approach should consider the risk profile of the underlying CTD, and we know that scleroderma CTD PH is one of the worst. And not only that, scleroderma PH can be multifactorial, is much worse than idiopathic PH, and when there's associated ILD, they fare even more worse. What has been seen that Selexipag is a drug which is well tolerated and more importantly delays the progression of PH irrespective of CTD subtype, but much better in scleroderma PH subtype. And it works very well, either initiated as dual combination or as the Triton has shown that it may significantly delay the progression of PH even when initiated as a triple combination to start with. Thank you.
Thank you, Rath. It was a wonderful treat to hear you, and so precisely and accurately you have given the position of CTD-related PH, their outcomes, and how it has been progressed over the time. That PH is a indicator even in all CTDs that the patient is really not going to do well, and you really need to be very, very aggressive in them. Triple therapy upfront in the trial, Triton Trial, which was published just last year, was something which was very, very, I think, need of the hour to realize that, we were in the habit of monotherapy and then taking long time and then going to dual and then triple we couldn't, because most of the patients couldn't afford to get the drugs from abroad for that reason. So now I think the things are so clear, and I remember that most of the clinical trials of pulmonary hypertension required systemic sclerosis group where FVC was more than 70%. They were very precise that you need to be more than 70% in FVC. And at that point, I didn't understand why is this FVC 70%, why not 60%? But now going through the data which you have shown, it's very clear that it is out of proportion to the lung involvement. And it's not the lung, it's the vascular disease which is causing it, and it carries its own bag of worse kind of prognosis and survival. I'll move on to the next speaker, Dr. Vikas Kohli, and he's going to take us through the cardiological aspects and, of course, what the cardiology practice sees pulmonary hypertension. So over to you, Vikas.
Thank you very much. It's an honor to be here with you and Dr. Rath, and hope to enlighten subsequently after listening to Dr. Rath's talk. So I'll be speaking on Selexipag in the treatment of pulmonary hypertension, but we'll cover some basic issues also related to the diagnosis, assessment, and classification without trying not to repeat anything that's already been said. So let's go through a bit of a background of pulmonary arterial hypertension. A definition has been, one has already heard about it. The outcome is dependent on early detection. That's what I want to highlight. This will be a major issue, as literature has shown repeatedly. The earlier the diagnosis, the better the outcome. Pulmonary hypertension per se is, as per WHO, classified, and I don't need to repeat this. Our focus mainly as a cardiologist is pulmonary arterial hypertension or the left-sided heart disease. Definitely CTE-PH is a smaller group, and an unknown or multifactorial mechanisms do play a role in significant number of patients. Globally, this is a very widely spread out disease, still worldwide not recognized enough to be treated, and early diagnosis needs to be done by a higher index of suspicion by everyone who's dealing at the primary care level with majority of the patients. Now, pulmonary arterial hypertension needs to be organized is an editorial published in 2022. And basically, yes, we do need to organize ourselves. The organization part, and this is for the audience who's starting to see pulmonary hypertension, be familiar with the treatment, and one has to be very clear about the classification, the functional class, that is the patient, how functional he is, understand the echo report, that's extremely important, and I'll walk you through a little bit through that. Other lab tests which have already been spoken about, management protocols, which I shall not be going through every single management protocol. Mechanism of action of drugs is very important to be familiar with this. I'll have a slide or two on this, and the follow-up routines and the role of Selexipag, where it comes in after we talk about the risk stratification for survival. This is a very, very important point, which I'll be talking about subsequently. So in the drugs, basically, there are three main pathways: endothelin pathway, nitric oxide pathway, and prostacyclin pathway. And we have been familiar with the endothelin receptor antagonists, and we've been familiar with exogenous nitric oxide in the ICU setting. We have also been familiar with the oral phosphodiesterase type 5 inhibitors. We had till now, mainly for the outpatient, these two group of drugs available to us. Nothing was practically available here. And now with Selexipag, that is to be added. I'm very excited to hear about the triple drug therapies in the connective tissue disorders, but in cardiology, the issues might be slightly different in their outlook. Now, before we get into that, functional assessment of pulmonary hypertension, as simple as it may appear, WHO class 1, 2, 3, 4 are extremely important. All studies are based on this. One has to be familiar, and one has to classify one's patients according to this. This is one of the indicators which will determine the outcome of your patient. Now, diagnostic algorithm, various studies of various diagnostic algorithms and tests, and I shall briefly touch on them. But the first starting point is your non-invasive assessment for pulmonary hypertension after you've had symptoms, signs, history, physical exam, by which you may suspect the patient to have pulmonary hypertension. So there is a very clear group of secondary signs of pulmonary hypertension. Now, an echo report, which is done specifically, for example, in a patient with COPD or with systemic sclerosis or lupus for that matter, sent by specialists who are looking for early pulmonary hypertension, has to talk of these secondary markers. These include the ventricle size ratio. If it's more than one, is very indicative. Pulmonary arterial Doppler, the time taken to reach from beginning of the arterial Doppler to the peak is referred to as acceleration time. It is shorter in severe pulmonary hypertension. Normal is more than 110 milliseconds or 120 milliseconds, depending on what you look at. But if it's less than 105, you're talking already of pulmonary arterial hypertension as a secondary indicator. RA area more than 18 centimeters square in adult literature. Septal flattening, the D sign or the donut sign, is a very, very clear indicator of pulmonary hypertension. The pulmonary insufficiency early diastolic velocity more than 2.2 is a very reliable secondary indicator, not the primary indicator. An IVC diameter more than 21 millimeters is also a secondary sign. So you have 6 secondary signs on echo, which a report evaluating pulmonary hypertension in any age group should be talking about. So you have these pressures calculated from the tricuspid regurgitation, and we'll talk about the velocity also in the next slide. And based on these plus secondary signs, we classify the probability of diagnosis of pulmonary hypertension as being low, intermediate, or high. This is not outcome. This is probability of presence of pulmonary hypertension. Now, you may have a patient with a TR gradient of 90 or 100, and you think is idiopathic pulmonary hypertension. In those cases, there is no issue about whether it is low or intermediate. This is definitely straight away high, clear-cut diagnosis of pulmonary hypertension. You eliminate other causes and you end up with idiopathic, which in significant number of cases will remain to be one of the most common causes. But depending on your pressures, if it's less than 35 and you have secondary signs, it falls in the intermediate probability of diagnosis of pulmonary hypertension. 35 to 50, you don't need a secondary sign. It would directly fall into intermediate category. And we are talking about systolic pressures, not mean obviously on echo. If it's 35 to 50, yes, you need secondary signs. It would fall into the high group of probability of PH. More than 50, you don't need a secondary sign. It would directly fall into the high probability of PH. If you look at the same thing with the velocity of tricuspid regurgitation, you're talking about low, intermediate, high. These numbers translate into the pressures directly, which is just a simple mathematical calculation, which the echo machine does automatically. I suspect most of us doctors are not very good at calculating these numbers, even using a calculator. So here, one actually should be looking not at the printed report, but the diagrams or the pictures which are printed with the echo. And one should see if you have these secondary things measured and documented and sent to you along with the report, and whether the TR gradient velocity or the gradient mentioned here is in this range or not. So this is how you classify your patient as having a low probability of pulmonary hypertension, intermediate probability of pulmonary hypertension, or high. This is accepted according to the European Heart Association for Cardiology, according to the American College of Cardiology. Both over the board accept these criteria for low or intermediate or high category. Now, we do not cath all our patients. We do not do a right heart cath because our patients are presenting very late. By the time they reach us, their PA pressures are already 70, 80, 100, 120 or suprasystemic. So should we do a cath in those patients? I have myself been in a situation where if you do a right heart cath in a patient with that, there is a small percent of morbidity associated with prolonged admission, and subsequently those patients we categorize as high risk diagnostic cath and do not undertake them for an immediate diagnosis. But if your patient falls in the intermediate or low and you want to confirm the patient's having symptoms, nothing else is fitting in, then mean arterial pressure above 20, wedge less than 15, and a PVRI of more than 3 Wood units is what we are looking at. So those are the numbers that we look at. In my personal experience, I do not come across a low risk group or low probability of diagnosis at any stage. I usually come across either intermediate or high straight away. We need to see more of the low probability of PH, and then we are saying that yes, probably we are diagnosing a lot of cases. Cardiac MRI is something in my experience I'm not routinely doing, and I need to mention this. This is not a replacement for cardiac cath or echocardiography, definitely not the first test to be done. I'm not even sure if the interpretation at all stages is going to be according to the international norms, especially for the right ventricular and diastolic volumes and the type of subgroup of patients that we are seeing. So again, a mention about the secondary criteria, looking at tricuspid regurgitation and the secondary criteria, we classify the patient for probability of pulmonary hypertension. And then once you have a patient who's categorized accordingly, an intermediate risk or low risk or a high probability of diagnosis, sorry, I shouldn't be using the word risk, then we decide on the management of the patient. Now, the challenges in diagnosis is basically a lot of studies have been referred to and talked about, but the basic data I want to highlight is at the time of referral or first diagnosis, 61% of patients in the REVEAL or referral study were already in advanced stages of disease, and of these patients, only 30% on a PAH-specific medication. So we are looking at basically a condition which is heading towards mortality. The outcome or the time of mortality is dependent on early diagnosis, but internationally, patients are being diagnosed at a late stage. So that is where our role comes in. This is a very interesting study where survival in patients was discussed way back 10 years back, and the basic mortality indicators were male gender, RV function, exercise limitation. 1 year survival, 82%, 2 year survival, 67%, and 3 year survival, 58% in a multi-center study in the modern management era. before Selexipag was introduced. So this, I think, is one of the landmark slides. Now, if you intervene, and one has to understand this, if you intervene in the if you do not intervene, this is the pathway the patient is following: progressive deterioration and ultimate mortality. Now, if you diagnose early and intervene early, then you can change the class of patient, and I'll be talking about that in a little while. And this is what the outcome and the curve is going to look like. Regular monitoring, medical assessment, echocardiographic assessment, and follow-up. But if the patient reaches you here, and then you get ahead with the intervention and the therapy, this is the curve the patient will follow. And there is a vast difference between these two curves and the functional capacity. Now, risk calculation is something very different from the probability of diagnosis. So risk calculation has been studied by the French PAH registry, the Compera and the Sapphire studies. And basically, one is looking at WHO classification, functional class 1, 2, 3, 4, 6-minute walk test, right atrial pressures as assessed by echo, or if cath was done on cath, and cardiac index. The Compera and Sapphire looked at a few more parameters, but basically they said that if you have these risk factors, you can classify and suggest how long a patient will survive at 1 and 5 years. US-based prognostic risk stratification numbers were different. In the REVEAL registry, they looked at the 13 parameters. In their main study, REVEAL 2 and REVEAL Lite 2, they looked at 7 parameters right here, of which, interestingly, heart rate and systolic blood pressure and renal insufficiency were also included. If you carry a low risk score less than 5 or equal to 5, intermediate risk score 6 to 7, or high risk score more than equal to 8, then one is talking about prognosticating right away with this. So here is different registries, including the US, French, Compera, Sapphire, and 5-year survival across the board for low risk patients, as categorized by the scoring system earlier, is somewhere in the range of 89 to 97%. So you can take a 90%, almost a 5-year survival, if your patient falls into the low risk prognostication index. Now, treating to low risk status can improve prognosis. Suppose you have an intermediate risk patient, score of 6 or 7, more than 5, then your treatment is going to be geared towards moving this patient from intermediate to low risk. And this is where the third drug comes in. Formal risk calculations can help you determine your patient's predicted 5-year survival. We looked at that. Multiple registries, thousands of patients, PAH, those who achieve low risk status, particularly in the first year after diagnosis. That is the index at which we are looking at where does the patient fall 1 year after initiating therapy. Does the patient fall now in a low risk stable status? And I will exemplify all of these. Then you are talking about a better likelihood of survival. So prognostication, and I underline this statement, is not at diagnosis. Prognostication is initiate therapy, follow regularly, evaluate repeatedly, and try to move the patient from intermediate to low risk, or from low risk to keep him stable in low risk. So this is an excellent chart. One is looking at impact on survival per change in risk category. So stable low risk, this is stable low risk. This is where you want your patients to be diagnosed and treated. But suppose you're looking at high risk patient who is relatively stable, this is the curve he's going to follow. So survival is less than 20%, a 5-year survival with a high risk. This is the stable intermediate group. If you move your patient from stable intermediate to a stable low risk group, you are looking at this outcome. Much better than stable intermediate, but not as good as stable low risk. How does one work on moving a patient from an intermediate risk to stable low risk group? And that is where the triple therapy comes in. We have had phosphodiesterase type 5 inhibitor, endothelin receptor antagonists. You start your patient at diagnosis, depending on how sure you are of the diagnosis, that is intermediate or low probability of diagnosis, or intermediate or high probability of diagnosis. If it's intermediate, I tend to start on both of them simultaneously in 3 months. And I categorize according to the risk stratification. You may follow the French criteria, or you may follow the US criteria for risk stratification. And you then have to try and move your patient from intermediate to the low stable category. If you're able to do that with 2 drugs and achieve stability, continuing stability, you have achieved something which is going to affect the outcome of the patient. But if at any stage, the first assessment after starting drugs is at 3 months, and 3 monthly follow-up in the first year after that. If at any stage you find that there is any indicator telling you the patient's category has moved towards an intermediate group again, you immediately initiate the 3rd drug. We have never had the 3rd drug available in India. This is the first time I'll be putting my patients on a 3rd drug, but it is already quite long down into their life cycle. Only the new patients would face this, what I'm discussing right now. So you initiate 3rd drug the moment you feel he is in the intermediate group, and then you move him back there, and that is how their survival gets affected. This is a significant step forward in our regimen for management of patients, not just to initiate on 2-drug therapy, combined therapy, but also to monitor them regularly. Now our monitoring is going to be more intense because we are looking at seeing very closely patients who can move from one category to the other. And if they do, I need my patient on the 3rd category, on the 3rd drug. So this is where Selexipag in the treatment of pulmonary arterial hypertension comes in. First publication came in 2012, listed in Novel Drugs 2015. Gryphon studies already been talked about. Large international multi-center long-term phase 3 study, double-blinded placebo-controlled. Primary outcomes were measured. 1,156 patients, 80% on background treatment for ERA and phosphodiesterase type 5 inhibitors, as majority of our patients are already on it. Up titration of Selexipag allows each patient's maintenance dose to be individualized based on tolerability to a maximum of 1,600 microgram BID, and morbidity or mortality events you're looking at, variety of them were looked at in this study, and parameters which were monitored, functional class 2, 3 at baseline were monitored, and the primary composite endpoints with a p-value of less than 0.001, risk reduction 40% already highlighted by Dr. Rath, significant primary endpoint in compared to placebo was there, and various other parameters were also included. Other types of PAH were also included in the study. The Gryphon study with Selexipag met its primary endpoint in patients with PAH. Selexipag reduced the risk of morbidity, mortality by 40%. Efficacy of Selexipag was consistent across subgroups, age, gender, functional capacity, PAH etiology, and background PAH therapy. The overall tolerability profile of Selexipag in Gryphon was consistent with prostacyclin therapies, and the patients in the Selexipag group received Selexipag for a median duration of 70 weeks in this study. So this is risk reduction 40%. We've already highlighted this. Starting dose was 200 microgram BD. After 1 week, go up to 400 microgram BD. Next week, 600, 800, 1,000, and you continue up till 1,600 microgram BD, unless the patient has symptoms. Commonest symptom, nausea. Second common symptom, headache. Third common, vomiting, diarrhea, GERD. And so mainly GI symptoms. And one of the peculiar symptoms is jaw pain, which you find in these patients, which you find in all patients who are exposed to, most patients exposed to prostacyclin, about 45% of them. So this is a study which was done in Britain. This is off-trial study where a real-time shift was being made of patients on inhaled prostacyclin or IV prostacyclin to oral. And they found this is the group of side effects. Most commonly 65% nausea, GERD, vomiting, diarrhea, 65% headache, 65% jaw discomfort, 45%. The moment you find this, you go to a dose which is lower. And if at a later stage they want to try the higher dose, they could do that. So all these are minor changes which one is noting. There is no significant major side effect which is noted in these patients, except for clinical worsening of PAH. Now, the only category one would be wary of in starting Selexipag or some such drug, or a new drug would be in a category where a patient is function class 3, even class 4, with symptoms which are extreme degree and has decreased right ventricular function already on echocardiogram. Those are the patients one would watch for, and if he has any worsening, I would not want to continue him. Rest all patients can take Selexipag. There is no other absolute contraindication in terms of your echocardiographic finding or functional class. So characteristics of Selexipag titration, in the real-time study, the study is titled real-time dose management of Selexipag, not the trial study. Mean titration period took a long time. It took 60 days plus minus 26. So 30 to 90 days is the time it will take to titrate the dose. The mean maintenance dose in a real-time study was 1800 plus minus 500. So you're looking at a dose somewhere around 1200 to 2400 per day. And subsequent dose changes at 6 months, about 75% had no dose change subsequently. So once you reach a steady dose, you're looking at a patient subsequently being on that. The results and expert consensus survey on treatment of pulmonary hypertension with oral prostacyclin pathway agents has been very good. And they've identified various clinical scenarios, mainly functional class 2 and functional class 3 symptoms and low and high risk hemodynamic parameters. And a variety of subgroups have been labeled where one can start, basically according to the recommendations. So we are looking mainly at subgroup functional class 2 and functional class 3 patients who would get started on pulmonary hypertension, that is Selexipag, who are already on dual therapy as suggested here. So to conclude, PAH is a disease very well known, well established. There is delayed diagnosis and late presentation. Earlier suspicion is needed. Dual therapy is started on majority of the patients who fall in the intermediate or high probability of diagnosis. Low probability of diagnosis, you can start one drug and may need a right heart cath. Also in those, current practice guidelines are based on these risk stratification. You may use criteria French study, criteria US-based study. And when you use those criteria, 3 monthly follow-up in the first year is what you need to do. You need to reassess the risk-based criteria at every visit. And once you do that, you have to make sure your patient is moving towards low stable risk. If you are able to move your patient low stable risk stratification, you are actually giving your patient the best chance for long-term survival. With dual therapy, if you've initiated and 3 months you don't see your patient moving upwards, you really need to consider adding the third drug at 3 months of initiation of therapy. And Selexipag is the first drug which is available to us, apart from the endothelin receptor drugs and the nitric oxide or phosphodiesterase group of drugs. Those were the only 2 groups available to us. Thank you very much for your attention.
Thank you, Vikas, for bringing in the most important points of assessment for the risk and that intermediate and high risk group where you need to go. So we'll quickly take the questions because it's already 2 p.m. and we have already come to the end of this webinar. But we have some questions, so we will quickly go through those questions. And first question is, how does Selexipag work with other prostacyclins such as Elioprost or Treprostinil? And can this combination be used together? Can you use 2 prostacyclin inhibitors together? Because I think I'll leave this question to you. Quickly, please. You are mute. Vikas, you are mute.
Yes. So we need to shift from one to the other. We don't have the option of, under very rare circumstances, we don't have the option of intravenous inhaled as yet in our country. But if they are already on that, we need to shift to the oral. The shift has to happen. We can't give both together.
The second question is in functional class 3, how many different group drugs can be given? So I think you have answered it very well already, that there are 3 drugs, 3 combinations possible, triple therapy. And mostly you start with a double therapy, but is there a situation where, because you will address and start with a triple therapy now, it's available?
Yes, I would be doing that in our high index of suspicion of diagnosis. So majority of our patients are coming very late. The PA pressures are very high. They are already on their curve of towards, mortality in several years. So why not give them the best chance? So those late presenting patients, I don't want to wait for 3 months and then move to the triple. I would start with triple right away.
So now one more question is the Riociguat, Mesentan, and Selexipag triple therapy in severe PH, your experience and comments. So we have not used it. I have no experience to say that these 3 combinations have been used together. So your comments, Vikas, and then Rath, if you have any experience about these 3 drugs being used.
No, not to be used together.
So generally we are combining with...
There are combinations of Mesentan, Riociguat, and Selexipag also. My experience with Selexipag has been in 2 patients where I used the original Uptravi for almost a month. My gut feeling is, by looking at those patients, is Selexipag is going to be less well tolerated in our patients. And we might have to start at 200 microgram once a day and then gradually escalate it to twice a day. And in my experience, nausea and vomiting is predominant, much more than headache. So our patients, my gut feeling is, and we'll see what happens as we go ahead, is they're going to tolerate less doses of Selexipag as compared to the Western population.
So because any particular group where Riociguat, Mesentan, and Selexipag is likely to be used, is it the group 4 group where it is more likely to be used?
I wouldn't have an experience on that, and I wouldn't want to say yes without experience.
True, right. Rath, there is one more question for you. How beneficial is Selexipag vis-a-vis Ilioprost in scleroderma pulmonary hypertension?
Well, there is no, comparison head-to-head with Iloprost. Inhaled Iloprost is definitely one of the good drugs. But as you can see, Selexipag definitely scores over oral teprosterol, which probably is now the standard drug for, world over. So it definitely puts it much above that in the prostacyclin group. And as you've seen with the Griffon and Triton, I think the combination works pretty well.
So as somebody has quickly added another question, that is there any role of specific study of Selexipag in scleroderma? I think Griffon has enough given the data that there are so many patients of scleroderma with pulmonary hypertension in that group. In fact, more than 200 patients, and the data is amazing. Actually, it is showing 40% reduction in the events in these patients to happen. Actually, hospitalizations and events in the follow-up period. So I think the data of Griffon study is amazing, and I think that is what the most of the clinicians will be happy to use it. Finally, there are questions related to respiratory, so which I could not do it because of shortage of time. I have a question from Chandramani Punjabi, my friend, a pulmonologist, who was asked a question about will it work in interstitial lung disease, Selexipag? So that's one question. And second question is how long it helps for mortality rate in PH, COPD and severe PH more than 60 to 70 and RV failure and signs and your comments. Okay, sir. So my dear friends, those pulmonologists who are tuned in, pulmonary hypertension out of proportion is what we are looking for. This is a different phenotype altogether. You will have it mostly in the COPD patients where the lung functions are not so bad. Emphysema is not there. You need to have your lung function assessment, which shows that the lung capacities are like above 60 to 70%. Their diffusion capacities may be impaired. That does not matter. And the CT scan doesn't show that kind of destruction or emphysema, which can account for hypoxia, acidosis, hypercapnia, as well as destruction of the pulmonary vasculature, which could be accounting for the pulmonary hypertension. So if you don't have that, the pulmonary hypertension in this group, which is severe, is out of proportion. And this is the one in which you think either there is associated idiopathic group 1, or there are other things which could be contributing to it, where the anti-PH drugs have been used. I'm sad to say that whether we talk about the trials with sildenafil, whether we talk about trials with bosentan or Ilioprost, the 3 drugs which have been tried in literature, and we have 2 meta-analyses available. However, the results have been very disappointing. I always say anti-PH drugs in respiratory medicine has good, bad, and ugly. The good is it shows that hemodynamics improve. It shows that some amount of quality of life of the patient improves. And it also shows some impact on the exercise capacity of the patients. But the bad is that it leads to more a fall in PaO2 in this patients, almost about 7 to 10 millimeter fall, which happens. So their resting hypoxemia develops in this patients, or it worsens on starting that. So you have to be very cautious when you're using it. You should be very clear with your aims looking at it. And surprisingly, the data shows that RCTs failed to show any beneficial effect of anti-PH drugs in group 3. However, non-RCT trials did show improvement. And most of the improvement was in the group which had sildenafil or bosentan. Selexipag has been tried. Selexipag has, the article has appeared in Curious, where 6 patients of COPD with out of proportion pulmonary hypertension, that is, we call when it has got mean pressures of more than 35, or it's between 30 to 35, but we are talking about the group in which cardiac index is low. So in those group of patients where it has been tried, they showed that it did lead to increase in 6-minute walk test. It led to decrease in mean arterial pressures. And but the 6 number of patients is only 6, which is too small. But as we all know that the assessment of pulmonary hypertension in respiratory patients is very difficult. All the echo findings which Vikas has said, invariably because of the poor window, it is very difficult to comment upon it. And it is highly inter-observer variability is too huge. So somebody writes mild, another writes moderate. So it's very difficult. Doing a right heart catheterization, again, because Vikas has brought a very good point that by the time these patients are sick with group 1, when we talk about group 3, they are anyway sick. So at that point of time, it becomes really challenging to do a right heart catheterization. But the group where we do perform right heart catheterization essentially is a sarcoid associated pulmonary hypertension. Lungs are not bad. It is primarily a pulmonary hypertension where the PH therapies are the only ones which have been shown to work, and has been data enough to suggest that you can upfront use a dual therapy. Triple therapy, of course, I don't remember any data on sarcoid-associated pulmonary hypertension. As far as ILDs, for a pulmonologist, this is something like which is going to happen to all ILDs. One day they are going to come up with an echo report showing mild, moderate, severe. All varieties of PH will be reported on, but their lungs are bad. So again, in this group, my personal take is always to look at their lung functions. That is the vital capacity, the total lung capacity, and also to look at their destruction in the lung parenchyma. If you find that the pulmonary pressures which have been quoted in the echo, and which I think Vikas has taught us so well to see, that not only look at the pressures, look at the tricuspid regurgitant velocity, look at the secondary signs in it, very importantly, then you can take a call that perhaps this patient may not deteriorate after starting the anti-PH therapy. But in these situations, you can't start upfront double therapy. So you need to tread the ground very carefully, starting with one. Our practice is to always use PDE5 inhibitors and then add on to ERBs. And of course, it is considered that the prostacyclin pathway, which is again the anode suppressor pathway, drugs are likely to do better in patients who have got underlying respiratory disease. It has been always felt. But however, we do not know the effect because we could never get the drug to use it. So I'm sure that the data will come in, whatever the data is too scanty at the moment. But this is one area in comparison to where Vikas is placed or where Prath is placed, where they're comfortable in using the anti-PH drugs. So a pulmonologist is always on a thorny bed where he knows that actually the patient may come up in 2 weeks with more hypoxia. You need to withdraw the drug immediately. You need to up titrate the dose very, very carefully, as well as adding on the second drug. when you are very comfortable that the pH is playing a significant role in producing this exercise desaturation, which is happening in this patient, excessive decrease in diffusion capacity, which we see. And perhaps the most important thing is we look at the differential between the decrease in forced vital capacity as well as the decrease in DLCO. So if it is disproportionately reduced with the ratios of more than 2, better is even 3 or even 4, which indicates that the diffusion capacity has gone much more beyond the lungs could explain for it, where you start wondering that pH may be playing a significant role for patient symptomatology and of course the future survival, where the anti-pH drugs can be used. Pediatric dose of Selexipag is the last question which I can see for you, Vikas, and then we can quickly wind up the rest.
So we start under 5 kilos. I don't have experience, but above 5 kilos, we start with the 1/4 tablet of 200 milligram, 50 microgram is what we start with. And that's how we start using the dosage and double it up subsequent visits on a weekly basis.
Last question is that has Selexipag shown to improve the mortality in pH?
I think we are looking at a better quality of life and a better end point. The study parameters were endpoints.
Yes.
One of the endpoints was mortality also. So to some extent we can say, but over the board saying it's going to improve mortality, I don't think we have anything which improves mortality.
Yeah, so my understanding of Griffin's study is that it does show a reduction in events, but not the mortality. I don't think so mortality was an endpoint considered there. But ultimately, if the events and the hospitalizations are reduced, it is going to affect the mortality. But how it is going to come out, I think the future ongoing studies will be able to answer that question more accurately. And especially lots of patients were already on mono, dual or dual therapy prior to being given Selexipag. So I think this answer at the moment is lacking. And with that, I would like to return the proceedings of today's webinar back to Nitin.
Thank you so much, sir. First of all, to Talvasar for giving this much of time in your tight schedule also, sir. And on behalf of MSN Labs, I would like to say sorry to all my pulmonologists and chest physicians who have joined, who could not experience your, in fact, talk which you have prepared for them. So thank you so much, sir. And my sincere thanks to Dr. Rath, sir, as well as Dr. Kohli, sir, also for your enlightening talk about this particular topic as a whole. And I think that most of the questions are already been answered, and we can have this particular session as a reference talk, particularly to all the rheumatologists.
If I can just put a final word. So my experience in scleroderma ILD patients is because they have severe Raynaud's. And for that, we need to often combine ERAs, endothelin receptor antagonists with PD5. So we have seen a combination has not deteriorated lung function in them. So at least in scleroderma ILD, I think we could go with the combination, even in PH-ILD. Thank you.
Thank you so much, sir. In fact, just I was sharing that we can keep this session as a video, and it can be a reference to all the rheumatologists, cardiologists, and pulmonologists to how to treat pH and how to proceed now with the all the available therapies available, because this was the only thing which was not available in the Indian market. So now we are bridging this gap also. So thanks a lot from my side, and thank you so much, sir.
Thank you so much.
Thanks.